go.
Okay. Sorry, everyone out in telehealth land. You didn't miss anything. I don't know. But from RQIW, they're basically building the rationale for including indications in antimicrobial orders. And with this, they were specifically working with the internal med specialists, but really focusing on the jerseys and the residents, helping them to learn a new process that they can spread throughout the hospital. As we've been going along, the process has been up and down, really, and it changes as we get new learners into the hospital. So one of the things that we've tried to do is also engage with those learners as they come into the hospital, to meet them and tell them about this project that's going on and the rationale for including indications along with your antimicrobial orders. As we've been going along, we've also had nursing students and myself doing random indication audits where we're going through charts in the hospital of randomized patients and really looking at if that patient is on an antibiotic or an antimicrobial, is there an indication anywhere in the chart? And what we were finding is roughly a quarter of the time at both the general and the Pasco, there was nothing in the chart to document why it was started at all. And so this is a troubling statistic for me and something that I hope that we can really push the indication and documentation piece, because it does create a streamlined process for everyone else when they know what that indication is and what to monitor for. And as pharmacists, is this the right drug for that patient? If you don't have the indication, it really hampers your ability to clinically intervene. So the building blocks of our stewardship program in the first year, the biggest pieces were awareness and education and the interventions. But a huge part also was the data collection. Not really, when we started the program, it was really trying to figure out, okay, where do we even stand? How do we access this data? And for that, the trials and tribulations of data analysis, I'm going to hand it over to Jason for a little bit here.
All right, so when I started with the program as a research analyst, so I was tasked at a point 2 position to get the data and tell us where we're at, because really this is what it is. It's tough to know where you're going if you don't know where you've been. So how much are we using in terms of antibiotics and things like that? So that's kind of where we started, barreling down this highway at 100 miles an hour, but we got to see where we were to see where we're going to go. So one of the first things that we did was undertake basically a 4-year retrospective review of our antimicrobial use in acute care. So basically pulling data from Centricity, BDM, the pharmacy system, to just get an idea of how much we're using in terms of antibiotics. So I entered data monkey mode, and we started pulling data and putting everything together and trying to see where we could go. So we looked at intensive care units to see our usage there. We looked at different medicine units to try and compare usage there. We looked at surgical units and different things. So just trying to get an idea of where we're at and what use has been like over a period of 4 years to see if there was, continual increases, or if there are spikes, or if there are spikes at certain times of years, which might give an indication of sort of seasonal use and things like that. We're still sorting. There's a lot of data there, so we're still sort of sorting through, trying to make sense of it, see if there's things that we can pull out, see if we can make sense of where we get these big giant spikes and things like that. So there's a lot of information, and as I said, we are still trying to sort of piece through that. And one of the hardest parts is really trying to decide, well, what are you going to use for a metric? So we can pull automatically DDDs through the system, so that's something that is defined by the World Health Organization, and they have a sort of calculation that goes with that. But is that the best method to use? Should we be using days of therapy? Should we be looking at different metrics like patient outcomes, so maybe a length of stay, or C. diff rate, or rates of other resistant organisms, MRSA, and things like that. So that's one of the things with any specific initiative that we want to do. We have to decide those things first. How are we going to measure this? And then from there, well, what is the sort of baseline that you're going to, the denominator that you're going to use to compare? Are you going to compare patient days? Are you going to compare based on number of admissions? Is it going to be unit-based, or are you going to go hospital-wide? So there's a lot of stuff that you really have to start considering. And even then, well, what benchmarks are we going to use? Are there benchmarks? Should we just be comparing internal, so within a unit or within a hospital or within Regina? Do we compare to populations in Saskatoon? Do we go provincial, national, international? And each of those comes with its own caveats and the way things are measured and the differences in populations and antibiograms and all those kinds of things. So it really gets to a point where it's kind of a chin scratcher. You really have to go, well, what is the best way to do this? And it almost comes down to sort of a situational thing. So I guess one of the biggest pieces of advice is if you're starting up an antimicrobial stewardship program, or if you're one of the other regions and you have less resources, it's really something that you want to get on top of is understanding your data and understanding the different ways that you can collect it, because there are a million different ways to skin this cat, and it's difficult to compare if you're not doing something that you can compare to other people. So, as Casey mentioned, one of the other things that we did, so that was looking at our sort of acute care data, where we stand basically within the hospitals in RQHR, really within the hospitals within Regina. But we also wanted to look at family medicine, community medicine. So that was something that we noticed there's not a lot of information about, so it was sort of important for us as we were developing the program to get a foothold in community and ensure as that's a place where the majority of our antibiotic prescriptions are happening, that we want to make sure that the people out there who are doing the prescribing are on board with the program. So we worked with our partners in primary healthcare to begin getting access to some of the information. Casey talked about our G12, as well as our long-term care sites. So we've been doing a lot of work there. We also wanted to take a broader approach even yet and say, well, can we get RQHR-wide data? So this kicked off sort of a year-long odyssey to try and get data from basically through the ministry, through the drug plan and extended benefits branch, so we could see, okay, what are prescribers in the RQHR doing? And this data encompasses physicians, pharmacists, dentists, optometrists, nurse practitioners, so a whole group of people that are prescribing antibiotics. Again, a huge data set. We're still sort of poring over it and looking through and trying to find ways to compare. Again, the biggest problem there is we really don't have a denominator. How do we compare based on population, based on number of visits for each prescriber? So there's a lot of stuff that we have to sort of dig through. And then as Casey said, really the big piece here is we analyze the data, we present it to our prescribers, and we get their feedback, and then we just rinse, wash, and repeat. We do this again and again until we sort of refine the data sets that we're looking at, and we're getting the type of information that these prescribers want. And I like to imagine, when we leave the clinic and the doctors are talking to each other, that this is what they're, comparing amongst each other, who's got the best prescribing habits. So we'll see. We haven't had any fights yet, so that's good, I guess. But yeah, so we look at, antimicrobial prescribing in community clinics. So we've looked at both urban and rural clinics. We've looked at acute care. So as Casey mentioned, we talked with pediatrics. We've spoken with physicians in ICU, emergency, medicine units, surgery units, all across the hospital. And of course, he also mentioned too, looking at antimicrobial and urine culture use in acute and long-term care. So another one of those things that we were, had to collect a lot of data for and start to make sense of things. Of course, there are always hurdles, like anything, and setting up this program, we had our share of hurdles, so that's me hitting the pavement there, as we have several times along the way. But one of the biggest pieces, and this is one that always comes to mind, is the data sharing. And it has been difficult, to say the least, to be able to get access. And as a program that was started in the RQHR with sort of the mandate to support other regions within the South, this has been one of the biggest barriers really for us, is trying to gain access to patient data and things like that to understand, well, what is being prescribed in maybe Cyprus, for example, or in Five Hills, and what are prescribers using and for what reasons. So this is something that, I don't know if there's anyone from the ministry listening, if you have any power to start chipping away at HIPAA and revising these things so that people who work in health can get more timely access to information. As I said, it was a year-long process just to even get an agreement in place with the drug plan, just to start getting looking at 2-year-old information. So having timely access to information is key for doing these quality improvement type initiatives. So that's something that you really have to consider when you're doing this, is where your data is coming from and whether or not you're going to have easy access to it. Data collection, so having the resources to collect your data. We do work in an environment that has a lot of good electronic systems. We are also a place that still does a lot of paper-based stuff, and so a lot of the information we want to get still comes from charts. So we've been lucky. We partnered with some of the nursing students at Sask Polytech, and we've been able to have them have student enrichment experiences, which allows them to come in and basically be a workhorse for us. So they've been collecting data, they've been reviewing patient charts, they've been helping to do analysis, they've been doing presentations, so all kinds of things. It's great. It gives them experience in the world of antimicrobial stewardship. It helps produce stewards in the next generation of healthcare workers. And then we benefit from basically free labor, to put it bluntly. But I think it's been a really good reciprocal agreement that we've had with them. So, I touched on the computer systems. So, again, the data monkey in me, when I walked into this job, I was like, oh, you guys have a pharmacy system. There's a laboratory information system. There's this SCM, and HIMSS has all this. Like, we're just going to get all this data, and it's going to come fast and furious. And I found out that nothing in this system talks to each other as far as those things go. So I became a sad data monkey. But we're working there, and as CPOE comes on board and things like that, I think a lot of that will help to fix some of these problems. So again, looking at this from sort of a setup point of view, this has been one of our biggest barriers, is we have to stitch together a lot of information from different systems. So if I get prescribing information from BDM and infection information from LIS, those are things that I just don't get it all in one sheet. You got to piece it together, and depending on the time frames that you're looking at, it can take a long time to do. Data quality is another hurdle with data collection. So one of the things I like to talk to whenever anyone coming into data science, the classic, you cannot polish a turd. So if you're getting garbage into your system, you will get garbage out of your system. And that's another barrier that we've sort of run into. Really, I think under the umbrella of incomplete data. So Casey talked about the indication piece. Well, that's something that is not always captured in, for example, BDM. So it's something that we had to go and look for in paper charts, which is why we required the extra help from these nursing students to actually go out and do reviews on paper charts. And we're not doing so good there as far as having indications with the original antimicrobial order. Another piece, the prescriber is another piece of information that may or may not be there. And even if it's there, it's not always legible. So, getting access to good, high-quality data so you can actually make valid assumptions and conclusions from that is another big piece to think about. So, education, it is huge. It is probably one of the biggest pieces of time commitment that we've had for the first year of the program, at least from my perspective anyways. We've spent a lot of time doing education pieces for current healthcare workers. So again, that runs the gamut of physicians, nurses, pharmacists, therapists. We've talked to social workers, clinical care aides, administrators, residents, students, trying to just stand up in front of as many people as we can and blabber on about how important this work is. And we do that in the forms of lectures or presentations like this, doing data reviews with, specific groups. We've had invited lecturers come in so that we can have presentations on antimicrobial stewardship type things going on outside of the region. Of course, future healthcare workers. So as I mentioned, we've connected with the Bachelor of Science in Nursing program through Sask Polytech and University of Regina. So we've been able to have some presentations and work together with those groups. Another big piece is the general public. So we've really tried to make sort of a campaign out of this to have people in the general public become aware of the importance of antimicrobial stewardship and why it is that we do this. So we've had interviews with the Leader Post. We did a presentation at the Regina Public Library. We were on the community radio, the CTV Morning Live, and the Global News. Between those, we've had probably at least 18 people hear what we wanted to say, which is a great start. I tend to bore any of my friends and family by talking about this at length whenever the topic comes up. And this here is the Campbell Collegiate. We actually were able to go at the end of the last school year to Campbell Collegiate and present to some of their, I believe, their grade 11 health classes, which is a great opportunity. And again, you've got future healthcare workers there, and kids who are going to the doctor with their parents, and everyone's looking for antibiotics when they get a cold. So it's a great place to sort of start sharing this message. And I would also emphasize too here, especially to other regions, the importance of your patient advisors. They're a great way to ensure that the message that you're trying to get across is going to get to the general public and is going to be understandable by the general public, and it's a great way to include people in your program. Antibiotic Awareness Week, that's another piece that we take part in every year, so it's happening again this November 13th to 17th this year, and it's a worldwide thing, so people are doing this everywhere, and again, just trying to raise that awareness and make people knowledgeable about the problem and that we can do something about it. We spent some time at Agribition last year. We're going to go again this year. It was great. We partnered with the SVMA last year, so the Saskatchewan Veterinary Medical Association. Obviously, antimicrobial stewardship is something that needs to happen in the animal world as well. So we had a great time. We spent the week there, and we got to talk to lots of school kids and parents and teachers and families, as well as producers. And a lot of representation from the vet world was really great at our booth to sort of spread that message that really stewardship should be a One Health initiative. So this sort of international initiative that recognizes the fact that human, animal, and environmental health are all intertwined. So there's no reason to do antimicrobial stewardship in hospitals if you're not going to do it in the community, if you're not going to do it in animals, if you're not going to do it in the industrial sector, because all of these things work together. So that was a very beneficial experience, and we're excited to go back again this year. Hurdles from education, really I think the biggest one has been actually physically speaking to a room full of physicians for the most part. And it kind of comes down to, not to place blame, but in the end, the buck kind of stops there. That's where the prescriptions are coming. Those are the people we really want to get to talk to and ensure that this message is getting out and ensure that they have the tools available to speak with their patients and educate the patients and ensure that the patient is aware that even though I'm not giving you a prescription, you're still getting the proper care. It's not that I'm denying you something. It's, this is the way to do it. The other piece we've had limited access to is dentists and optometrists. So that's another group that does a fair amount of prescribing, and probably a lot of that could be made better. And so that's another couple of groups that we want to get in contact with. And then the last piece that I'll talk about is research. So that's, really what my passion was coming in here. And I've always said that research drives innovation. So this is how we make things better by understanding where we are and where we need to go next. So again, money is tight. So we've been very fortunate that with the Regina Summer Student Program, we've had a couple of students over the last 2 years that have worked with us. So Christine, she worked last summer on the Knowledge and Attitude survey that we did, surveying community healthcare workers. She also worked this summer on the urine culture stuff that Casey was talking about earlier. And Shelby was working with us this summer. She was co-supervised by our own Dr. Mailman. So he came to us last winter with a great idea. Let's look at ICU, antibiotic use in ICU and antimicrobial stewardship. So we ran with it and had Shelby come on board again, and it was a great project, still being written up, but we'll see what it all comes out to in a couple of weeks here. So again, to other places, if you have these types of funding opportunities to get summer students on board, they can do a whole lot of work in a short period of time, and you can really get some good information out of them. Resident research project. So another one, this was Dr. Biker's research project. His supervisor was Alex Wan. Cheyenne was helping out with this one. So they were looking at management of Staphylococcus aureus bacteremia in the RQHR. So again, another good place for ensuring that proper antimicrobials are being used and are being stepped down or changed as appropriate as we go through. So they made up a pre-printed order, and he sort of trialed how that was going as part of his research project. again, a great way to promote antimicrobial stewardship, basically doing it on the back of something that's already happening, which was a resident research project. We take advantage where we can, scrounging for resources. So some other things this is what I love about research, is the things that have come out of this have really helped to push the program forward. So these tools for community prescribers, Casey mentioned the viral prescription pad. We have patient information pamphlets for a general one, a pediatric one, an emergency one. Our website, we have informational posters. We do a lot of antibiogram awareness. All of these things have come from that initial project about people saying, I think I need more information to teach my patients about this, and to be able to have these conversations with my patients. This has also pushed into now a follow-up project where PHAC got wind of this and said, hey, we're really trying to push and get programs to collaborate with each other. So we have a follow-up project that we actually need another person for, because we don't necessarily have the resources to do this ourselves. So it'll be kind of an interviewing family physicians in the community to understand if they find these tools useful, if they are using them, what kind of changes they would have. So if you know of any students or residents or people who are looking for a project, this is something that can be done. And because we got money from PHAC to do this, you can get paid. So if that's any incentive at all, we're willing to throw money at you as much as we can. So another big piece of this was strengthening our connections with the veterinarians and agriculture world. So through that survey and connecting with the vets, we've been invited to their AMR roundtable that they have in Saskatoon every year. The connections with the SVMA and the Ministry of Agriculture have been great for sharing information. And the brand new logo for the Antimicrobial Stewardship Program in Saskatoon. So again, we've made great connections with those guys up there, just trying to work towards sort of what would this look like as a provincial structure. Again, hurdles, like anything in research funding, it's hard to get money to do this kind of stuff, so wherever you can, grab it and go. And collaborators, surprisingly, has been a bit of a barrier. So really trying to get people from across the board involved in this. So we're not just talking clinical staff who are sort of frontline working on stewardship, but we need social scientists and psychologists and people in the community to be involved, because we need all of those different areas to look at how you change a system to get better prescribing. And I think that's enough for me, so I'll let Casey finish up.
Thanks, Jason. So we've just got a few minutes left, and what I wanted to go over is provide a brief overview of where we're going from here. And for some pieces, I won't have a lot of information because they're still very early in development. What I can say on the acute care side is, for the clinicians here in the room and the pharmacists here, I'll be around at the General and the Pasqua working with our ID physicians, whoever's on call, and seeing patients together with them in a team-based approach. And I think this is really important. There's a number of great aspects to this and just building that team, but also one thing that has stuck with me too is something Jeff said early on when I started coming over to the Pasqua, is that with a lot of these new interventions and programs, there's a lot of time Pasqua gets forgotten. And I want to make sure that that doesn't happen. And in the same vein, as we're building this program, we're looking at how to collaborate provincially with the different stakeholders, the different programs, the different pharmacy departments that are around the province, just to how do we, with antimicrobial stewardship being a global problem, we can do whatever we want here in the RQHR in a bit of a silo, but we really do need to work together. So what does that mean as we go forward in working together with everyone? And, just in the last few weeks, I've had some great engagement from, hospital pharmacists around Saskatchewan, including Shannon Neubauer, Barry Lyons, who are great at engaging with our program, and I'm hoping to continue that with the other programs that are around Saskatchewan. One thing that is going to be changing with our physician lead and co-lead system is, we were very fortunate when Dr. Wong was going to start with us. Unfortunately, given the amount of clinical coverage that's needed by the ID department, we can't run, having him in the program anymore and supporting us to the level that we need. So once again, we've been trying to be a little bit creative in how we approach that problem, because it is important to have that physician working with the program. So what you're going to see in the future is each of our ID physicians having a co-lead position within the program where they engage with a specific area or whatever in the health region. And what that looks like is still to be determined. This is going to be something in the next couple of weeks that we're talking about as a program. And from there, our ongoing activities, we've had some great responses from pediatrics, so we're going to continue that. The indication audit on 6F, we want to continue that and look at how we expand the indication piece as well. ASP education rounds, policies and formulary. And those are all going to be big bits and pieces that we need to collaborate on to work together. The last thing here is, as we continue to build the program, also focusing still on community and long-term care. As Jason was saying, with our ongoing activities in community, looking at how our tools are working and how do we improve them so that the clinicians are getting the most out of them that they can, and continue our surveillance in both community and long-term care so that we can improve prescribing there. I'll wrap it quickly up there. We have to continue our metrics and our student program. We've been very lucky to engage with nursing, but we're going to be expanding into hopefully having some pharmacy students joining us this year, as well as continuing to work with medicine. So, in that, we get the pleasure of working with jerseys and residents as they come through as well. So, looking forward to that. And just the last point I was going to make is that together with Saskatoon and a number of different stakeholders around Saskatchewan, we're trying to develop a symposium for this November, bringing those individuals that I was talking about from the province together so that we can start developing a strategy on how we support everyone else in the region so that we're all doing the same thing and supporting the same activities. And with that, I'll just open it up for questions. I thank everyone for staying as long as you did. It's very appreciated. And I'll open it up to the rule sites first if there's anyone on telehealth that has questions.